This is Randy Schell, and I'm making a video cast entitled Perioperative Hypothermia and Hyperthermia Just the Facts. It's developed to provide the foundational knowledge before an interactive flipped classroom session. The ABA keywords from 2010 to 2017 on temperature issues are shown here. For example, sweat glands innervation are sympathetic cholinergic. Some of the physiologic effects of hypothermia, for example, in the heart, lungs, and brain. Oxygen delivery issues, as temperature goes up, oxygen use goes up in the tissues. Hypothermia reduces oxygen use by the tissues. Hypothermia, some of the mechanisms like radiant heat loss in the operating room. How do we prevent heat loss? Things like warming the operating room and forced air warmers. And arterial blood gas temperature correction. When the temperature of the patient, for example, is cold, what happens to oxygen partial pressure, CO2 partial pressure, and pH? There are some related other keywords that will not be covered in detail, including febrile transfusion reactions, MH and thyroid storm, and inducing hypothermia during cardiac arrest and its potential beneficial effects. So let's move right into hypothermia and define it as a temperature less than 36 degrees centigrade as measured from a core site. And we'll define core sites as the nasopharynx, the lower third of the esophagus, because the upper third could have actually air from the trachea cooling it. Tympanic membrane is also a core temperature site, as well as the pulmonary artery catheter when the chest is not open. The forehead, axillary, oral, bladder are not considered core temperature sites per se. Patients that are susceptible to hypothermia include the old and the very young. The old because their autonomic nervous system doesn't work very well. In other words, they can't vasoconstrict to cold quite as well as you or I. And neonates because they have a very large surface area to lose heat from. There's some problems with hypothermia. One, enzymes, which are proteins, don't function as well when they're cold. Hemostasis is not as good when the temperature drops, especially below 34 degrees centigrade. Platelets don't adhere as well. Coagulation proteins don't work as well. Arrhythmias are often present, things like ventricular ectopy, and cold diuresis. The kidneys, when they're cold, do not concentrate well, and urine output can go up. Some benefits of induced hypothermia include cerebral protection in the presence of cerebral ischemia or hypoxia, and short periods of hypothermia in patients who are survivors of cardiac arrest. What are some defenses against being cold or hot? Cold first. Vasoconstriction is a major one, and the elderly patients don't vasoconstrict as well, so they can lose heat more. Another mechanism is shivering thermogenesis. When we shiver, we can create heat. Now, in infants, they have mitochondrial brown fat, which they can use to produce heat. We do not have that, but infants also have a very large surface area to lose heat from. When we become cold, this increased stress results in increased norepinephrine production. And increased norepinephrine can raise our vascular resistance, our pulmonary vascular resistance, can increase metabolism. Now, hyperthermia defenses against, we can vasodilate to lose more heat, and we can sweat to lose more heat. Causes of hypothermia include things like a cold environment, impaired thermoregulation as mentioned in neonates and elderly, drugs like alcohol, which vasodilates, and medical conditions such as hypothyroidism or large body surface area burns where we can lose heat from. How do we regulate our temperature? The thalamus and hypothalamus are critically involved in this, and our anesthetics tend to impair it. General anesthesia impairs our ability to vasoconstrict, as our volatile anesthetics are vasodilators, and also impairs shivering, a way that we can generate heat. If neuromuscular blockade is present, shivering can be totally blocked. Sweating, however, is relatively well preserved. Spinal anesthesia and epidural anesthesia can block the thermoregulatory control. The more spinal segments that are blocked, the more thermoregulation is impaired. So the higher your spinal, the higher your epidural, the more thermoregulation is impaired. Spinal anesthesia results in vasodilation, as does epidural anesthesia, and vasodilation can result in heat loss, decreased ability to vasoconstrict, and decreased shivering, mechanisms of heat loss for both general anesthesia and neuraxial anesthesia. If you look at graphically normal versus anesthetized patients and their thresholds for differing things, for example, on the left represents our thresholds for vasoconstricting and shivering, responses to being cold, and on the far right, sweating and vasodilation are responses to being hot. Under normal conditions, you can see that they're quite tight, around 37 degrees. Small changes in temperature can result in activation of those thermoregulatory thresholds. As opposed to anesthesia, the anesthetized state, you can see that those thermoregulatory thresholds are impaired, especially for cold, not as much for sweating and vasodilation, our defenses against getting hot. Let's look at the cold ones, and you can see down around 34.7, our vasoconstriction, our non-shivering thermogenesis, and shivering, but vasoconstriction and shivering being the top two ones are greatly impaired. And we have to get quite cold before these kick in and help us to stop losing heat. And sweating and vasodilation, yes, they're impaired some, but as you probably have seen in patients whose temperature is rising in the operating room, it doesn't take much, and sweat will appear on their forehead, and they can vasodilate. So our anesthetics don't impair the thermoregulatory responses to increases in temperature as much as they do to decreases in temperature. Some physiologic effects of hypothermia next. What about the brain? The brain is cold, the oxygen use goes down. And if the oxygen use goes down and you have intact autoregulation, blood flow to the head goes down also. MAC is affected by hypothermia. It is decreased as we get cold. Patients can take longer to wake up when they're cold. The EEG can be slower, and if you're monitoring somatosensory evoked potentials, the signal latency, the time for that signal to get through, can be longer. So letting a patient get cold who's having SSEP monitoring during scoliosis surgery, for example, can impair those SSEP signals. The cardiovascular system, vascular resistance both systemically and in the pulmonary vascular system can increase. Stress increases norepinephrine. Norepinephrine activates alpha receptors, and as alpha receptor agonism occurs, vascular resistance can go up. A patient with pulmonary hypertension who's allowed to get cold can get very high pulmonary vascular resistance in the right heart, could potentially fail in that situation. Bradycardia, slowing of the heart rate, as well as ventricular ectopy occur as you get cold, and shivering can greatly increase oxygen demands and require a much higher cardiac output in patients who are cold and shivering. Other physiologic effects, the respiratory system, as we mentioned, pulmonary vascular resistance can go up. Hypoxic pulmonary vasoconstriction can be decreased, and so as the alveolar oxygen levels go down in some alveolar units, your HPV doesn't work as well, so VQ mismatch gets worsened, and hypoxic drive doesn't work as well. And if you draw blood gas from a patient, as you're cold, the partial pressure of CO2 and oxygen actually goes down because these gases are more soluble at cold temperatures. And so on your blood gas, the partial pressure of oxygen and CO2 goes down, and the pH actually goes up, and we'll show that in another slide next. The oxyhemoglobin dissociation curve shifts to the left when we're cold and shifts to the right when we're warm. Now when we're cold, the coagulation system doesn't work as well. The platelets don't adhere as well, they don't release as well. The clotting factors are enzymes, which under cold conditions don't work as well. And the kidney does not conserve water as well when it's cold, and cold-induced diuresis can occur, probably mainly through an ADH effect, but also through renal enzymes and sodium exchange in the tubules being affected by cold. What about the effect of hypothermia on arterial blood gases? One of the key words that we mentioned at the very beginning. I've attempted to show this graphically in a picture on the left here. And when the temperature is cold, think of blood having a liquid phase and a gas phase. And when we're cold, the carbon dioxide and oxygen dissolves more in the liquid phase and doesn't create as high a partial pressure in the gas phase. Those molecules don't have as much kinetic energy bouncing around. Partial pressure drops. So with cold, the partial pressure of CO2 and oxygen go down. Conversely, when the temperature goes up, the solubility of those gases in the liquid phase go down. More jumps up into the gaseous phase. It has higher kinetic energy, and the partial pressure of CO2 and oxygen both go up. So when you draw a blood gas in someone who's hypothermic, you will see a decrease in PaO2 when it's corrected for that patient's cold temperature, a decrease in PaCO2, and if the PaCO2 is decreased, that's a form of respiratory alkalosis, and so the pH goes up. These are the classic effects of hypothermia on an arterial blood gas. What are some mechanisms of heat loss, and what's the pattern of heat loss in the operating room? The number one mechanism of heat loss is usually considered radiant heat loss. That is radiating heat from your body to cold surfaces like the walls of the operating room. So warm the operating room is one of the things that we can do to reduce heat loss. But conduction, if we're sitting and laying on something that's cold, like metal, convective heat loss, if air is blowing over us and we're uncovered, evaporative heat loss, if we're sweating, for example. The pattern of heat loss is initially a very rapid decrease in temperature in the first 1/2 hour or so in the operating room. And you say, well, why does that occur? And the major reason is not a total loss of heat, but a redistribution of heat. What I mean by that is if you feel your hands and feet before you go into an operation, feel it in a patient, for example, they're cool. And their core temperature may be warm. Well, when you put them to sleep, general anesthesia tends to impair the meta-arterial vasoconstriction that keeps that cool blood in the periphery. So as you vasodilate, that cool blood in the periphery mixes with the warm blood in the core, a redistribution from periphery to core, and the temperature drops, as seen in the graphic on the far right, where the arrow is, in the first 1/2 hour to hour. So the initial drop is redistribution, and then radiant heat loss takes over as the major mechanism of heat loss in most situations. So how can we avoid hypothermia? Keep the operating room warm to prevent radiant heat loss. The most effective rewarming strategy is putting a forced air warmer on the patient, not putting, for example, a water blanket behind them, or warming your IV fluids, or putting a humidivent in. It's forced air warming. That's the best rewarming strategy. What happens during rewarming? What are some of the physiologic effects? Well, as you rewarm, you vasodilate. And if you have a shock patient who's cold and vasoconstricted and you start to rewarm them, you can vasodilate them and unmask an existing hypovolemia, and the patient can then become hypotensive. Also, as you rewarm, oxygen consumption starts to go up and CO2 production goes up. And the patient may start to shiver as they're cold and during rewarming, and that is associated with increased oxygen consumption. And if you happen to be monitoring mixed venous oxygen, as your oxygen consumption goes up, if delivery is unchanged, the mixed venous will decrease, and myocardial ischemia actually can occur if oxygen demands go up excessively. Treatment, forced air warming for shivering, that is. Meperidine in low doses can decrease shivering. That's Demerol. In a sedated, ventilated patient, if you want them to stop a shivering, neuromuscular blockade can be administered. What are some complications of hypothermia? Well, wound infections are worsened. White blood cells don't work as well. Transfusion requirements can go up because of platelets not working as well and coagulation factors not working as well. Blood loss can go up. Cardiac events go up, dysrhythmias and MI. Duration of neuromuscular blockade is prolonged. Adrenergic activation, norepinephrine levels going up. Patient can be very uncomfortable and recovery room times prolonged. These are just some examples of complications of hypothermia, with at the top of the list often mentioned wound infections, blood loss, and cardiac events. Let's finish up with hyperthermia. Iatrogenic is usually the cause of hyperthermia in the perioperative period, especially in infants and children where either the room is very warm or you're using a forced air warmer set at a high temperature, and the patient's temperature starts to creep up. Infectious etiologies are another cause of hyperthermia. For example, if you were doing oral dental rehabilitation, pulling infected teeth, I've had patients that have gotten very hyperthermic. Drug-induced anticholinergic effects. Atropine, for example, in an infant can stop the sweating mechanism and reduce heat loss, and the temperature can go up. MH in someone who has received succinylcholine and/or an inhaled volatile anesthetic like isoflurane, desflurane, or sevoflurane. If you combine opioids and MAOI inhibitors, serotonin syndrome can occur and be associated with hyperthermia. Transfusions. If you've given either platelets or packed red blood cells and the temperature goes up, you need to think of a hemolytic transfusion reaction, yes, but a febrile reaction is fairly common. And in a febrile reaction where the temperature goes up, there is no evidence of hemolysis. This is one of the differences between a major transfusion reaction and a febrile transfusion reaction. Febrile transfusion reaction occurs in about 0.5% of red blood cell transfusions, 30% of platelet transfusions, and appears to be white blood cell mediated. And if you reduce the leukocytes, for example, filter out the leukocytes, transfusion-related febrile reactions go down. Metabolic causes of hyperthermia like a thyroid storm or pheochromocytoma, endocrine causes, rare but a possibility that you should consider. So the physiologic effects of hyperthermia, temperature going up, include the brain uses more oxygen and can worsen CNS outcomes if ischemia is present in the brain. So a stroke patient, letting them get hot, not a great idea. Interestingly, in patients with multiple sclerosis, even small elevations in temperature in the perioperative period may predispose them to an exacerbation and should be avoided. Cardiovascularly wise, if the temperature goes up, heart rate goes up, metabolic demands goes up, oxygen use goes up, and the patient may have a reduction in systemic vascular resistance and vasodilation. So if hyperthermia occurs intraoperatively, you should really think, have I caused this? Is it iatrogenic, especially in kids? But also ask the question, has a transfusion begun? Could it be a major transfusion reaction or a febrile transfusion reaction? Or triggering agents, given that MH might be considered as a patient having muscle rigor and modeling and increased CO2 production. Where's the site of surgery? Is there bacteremia? And what drugs have been given recently that might cause a drug-related increase in temperature? We've covered some foundational knowledge on hyperthermia and hypothermia. Let's look back at our keywords again as we finish up. Sweat gland innervation is sympathetic cholinergic. Atropine can block it, and if you don't sweat as much, you can cause an iatrogenic hyperthermia, especially in kids. Physiologic effects of hypothermia, we talked about the heart, the brain, and the cardiovascular, as well as the coagulation systems being affected. Temperature effect on cerebral blood flow, hypothermia is going to reduce it. Hyperthermia may increase it. Oxygen delivery issues, factors influencing. Hypothermia reduces oxygen use by the tissues, and hyperthermia increases oxygen use by the tissues. Hypothermia can occur more frequently in kids because of they having a large surface area compared to adults, radiant heat loss, and interestingly, in the very young, they have brown fat metabolism and can generate heat not only from vasoconstriction and shivering, but also non-shivering thermogenesis. With spinal anesthesia, we can lose heat as well as with general anesthesia, and the physiology tends to be vasodilation as well as reduction in shivering. The mechanisms of heat loss mainly at the top are radiant heat loss, but also convective, conductive, and evaporative. And in the perioperative period, how can we prevent heat loss? Warm the room, and forced air warmers are the two top things that we can do. And in arterial blood gases that are taken from cold patients, we realize that cold can reduce the partial pressure of oxygen, reduce the partial pressure of CO2, and cause what looks like a respiratory alkalosis in arterial blood gases. We talked a little bit about febrile transfusion reaction as a cause of hyperthermia, some endocrine causes of hyperthermia, and that hypothermia may be beneficial in patients post-cardiac arrest. This ends our short review of hypo and hyperthermia and the foundational knowledge prior to our interactive classroom, flipped classroom. Hope you have a good day.